on holding hearts before charts. Before meds had names, we had compassion. This one's for every nurse, past, present, and future. Let's go.
We are the calm in the storm, the beacon of hope. Every beat, every breath, we honor the oath. From night shifts to day breaks, loving our tone. Pepler taught us, connection heals more than alone. From Florence to futures, we redefine care, not just meds and machines. We're presence of prayer, with hands that comfort, eyes that see truth. Healing ain't a chart, notice what we do. We are nurses.
I think we're recording. Welcome back, everybody, to another episode of Peplau's Ghost. I am so thrilled with our next guest. Dr. Joshua Waddell is here with us. And I will say with Josh, usually I'm kind of inviting people that I somewhat know, or I think one of the people on the podcast know, but I just was really fascinated with Josh and his presence, and also is interested in podcasts, since he has his own podcast going, Mental Maps podcast, which again would highly recommend all and everybody who's listening here to check that out as well. But I always like this idea of cross-pollination, and so I really wanted to get another person who's doing podcasts here on the podcast. And so thank you, Josh, as always, for being here. And I want to also highlight that Dr. Sean Convoy and Dr. Melissa Chapman-Hayes is here as well. Also, to do some of that cross-pollinating, I just learned that Melissa has her own podcast as well. So super excited about that. So check that out. Measure What Matters by Elevate What Matters. So super excited that Melissa's jumping into who isn't, right? Everybody's got a podcast now these days, which is great. So that's excellent. So again, thank you, Josh, for being here. I'll kind of kick things off. And, what I like to do as well is just kind of dig into your background a little bit. And if you wouldn't mind kind of sharing, what is your path, your journey to being a psych mental health nurse practitioner? What kind of initially drew you to this space, and, go back as far as you'd like. And so thanks, just let you take it from there.
Yeah. So I have kind of an interesting space in the concept of mental health. Primarily, I started as a case manager as a bachelor's in psychology, right? And so I was living in Tennessee at the time. I didn't really care about school when you think about it back in the day. I raced motocross my whole life, and my mom was like, you got to go to school. And I was like, well, that's the worst. And then finally you get to the point where you're like, I've got to be an adult and this is not going to make me money. And so I was always kind of drawn to the brain. And so I got into case management, and then I got my master's as a therapist and worked as a therapist for a while in that space of treating everything, right? Adults and kids. I was in rural Appalachia. I was doing in-home work, right? So we were hike back into these caves, and we'd hike back into like deep parts and kind of find people and work with them, those kind of things. And one of the things that always drew me into these spaces was that we could help them therapeutically, but there's always this concept of medicine that was there. And I didn't understand it very well. I was a therapist by trade, and I wanted to understand it very well because it kind of seemed like some people maybe needed them, some people didn't, and I just didn't understand it. And so when the concept of psych nurse practitioner got really popular, Vanderbilt had created a hybrid program at that time. And so I got into that program and went there. And after that, I moved to a rural clinic in Florida. Rural health has always kind of been my thing. And so I ended up in a very rural clinic here in Florida. It's kind of this interesting juxtaposition where you have this beach world where there's wealth and, all kinds of stuff. And then you just go right across the bridge and it's like a third world country, and there's food deserts, and it blows your mind. And so I got up here into that space, primarily seeing everything, 5 to 95, serious mental illness, major depression, general anxiety, those kind of things. And then I had a Suboxone clinic as well. We had a lot of opiate problems in that. So we built that from the ground up, which was incredible, right? Doing some correctional work in that space too. But in that, one of the things I continued to find was that the medicines I had worked sometimes, and sometimes it didn't. And that was very frustrating, right? In our acute crises, absolutely it was helpful. But for our people with these mild to moderate issues, it didn't work. And so I got really interested in, is there something else, right? There's nothing worse than, you tried 3, 4, 5 medicines and they're just continuing to have these issues. And so that got me into the integrative space of both nutraceuticals, nutrition, but then also the use of like herbs. And so that kind of opened a door for me. There's so much more to this. And so that's kind of how I got into that space. I ended up leaving that clinic not too long ago. I have my own practice now and able to do a lot more lab testing and those kind of things, which is great. My passion is rural mental health, but I kind of came to a phase of life where I needed a break. And so I'm kind of excited to be in the private practice space. But that's how I ended up in the integrative concept.
Thanks, Josh. Would you mind kind of talking a little more about kind of that rural? Because University of Iowa here in Iowa, most people probably think it's the whole state is rural, which is inaccurate. But, is that just part of your background, kind of where you grew up, or what other things kind of draw you to that kind of population of working for people? Like, I loved how you kind of, paint a picture. You have to kind of drive up in the mountains and meet them where they are and that sort of thing. And that's always kind of exciting too. So you mind sharing a little bit about that?
Yeah, I grew up kind of in the middle of nowhere in Tennessee. Like the town that I grew up in doesn't even have a stoplight. To this day, it still doesn't have a stoplight. The only thing that's there is a Dollar General, So and that was big when it came. You would have thought like we got a Target or something. It was huge. And so like that was big time. And so in that space, the challenges of like rural Appalachia and then parts of East Tennessee, any rural area, really, it's just very different. A lot of things are taken for granted. The concept of food and good food. Unless you're growing it, the chance of you getting it's pretty small, right? And then we've seen societally where a lot of these, fast food and some of those things have kind of leveraged these areas because they know they can make cheap food. People need it. It's a lot easier to feed 4 kids at McDonald's than it is to go to Whole Foods. And so they kind of leverage these spaces, and you kind of find that. There was some really great research that was done by a sociologist at Yale, who she found that the presence of Dollar General alone would change the whole concept of your community, because then you're just going to get lower level stuff, lower quality things. And so that was something that I always seen, and that hurt my heart. It's like, why do people just born in these places all of a sudden have to live this way? And so that's really what got me drawn into that. And it's interesting, there's so many complexities and there's so many layers in it, right? But that in itself is a driver.
Thanks, Josh. Appreciate that. I'll turn it over to Sean.
Hey, Josh. So I'm looking at this more from, my question is framed really kind of from an academic lens, because for all of us who spend time working with students, we recognize there's typically 2 kinds of students that enter psych nurse practitioner programs. There are the traditional psych nurse practitioner students who, go to nursing school or jump right into graduate school, or, spend some time at practice and they just follow that path, right? And then in my mind, there's another kind of nurse practitioner, a psych nurse practitioner that I call the journeyman or journeywoman nurse practitioner, psych nurse practitioner, that have all different types of lived experiences, professionally, personally, that provides all this texture, right? And as an educator, I have to teach them a little bit differently, right? I'm getting this sense from your story, and knowing that you and I had a conversation a few years ago. For all this, that you're probably more in line with that journeyman psych nurse practitioner model, right? So my question is how does your journeyman trajectory kind of inform your unique ability to deliver care?
Ooh, that's a great question, Sean. Yeah, when I seen your name, I was like, I remember talking to you. Yeah. I think one of the big things when you think of like being a journeyman is you get a lot of information about stuff. And so you would think like, well, knowledge in itself isn't always going to translate. But what it does is it informs you how to sit with people. And I think that when you're in a journeyman, you get to sit with people in a lot of different ways. As a therapist, that's what you do, right? You learn to sit with people. If you're coming, I have students that are accountants or anthropologists or, whatever that is. And so they come at it in a different way. And so I think their ability to interact with people is very different. On the same edge of that, though, we do have challenges, right? I remember getting into nursing school and having to learn about the nursing component and being like, oh my gosh, there's the human body stuff and I got to touch people and there's this whole thing and I've got to deliver a baby. I mean, it was so wild, right? And so I was like, I just want to like talk to people, prescribe medicine. So that was a big shift for me in that space. But I think when you can leverage these qualities that those people have, man, they can make some really interesting providers and bring something a little bit different into those spaces. So yeah, I think that you definitely teach them differently. Many of us, I think, end up becoming very like visual learners a lot of times. So the videos and those kind of things, I know I've had to do a lot in my own courses of just get more videos in there and get more opportunities to wrestle with this stuff that's not just reading. I think that, in my opinion, a journeyman or woman ends up being those kind of people.
Cool. That helps me understand. And also, invoking Melissa here, it kind of helps me measure what matters. So I'll pass it to Melissa.
Yes. Well, my question is going to be a little bit on your background as a psychologist, since I was trained as a psychologist and I'm not a nurse. And part of it, you've mentioned the medication component of it is some of the many components of training that you get when you go the nursing route. So in terms specifically of integrating psychodynamic principles into prescribing, often psychopharmacology and psychotherapy, they're compartmentalized in modern systems. So how do you integrate those principles into the work that you do, or how have you and do you?
So as a provider, I always practice out of Glasser's work. I love William Glasser's work and choice theory. And so the concept of needs made a lot of sense. And so as a therapist, you can spend a lot of time in that. As a med provider, especially in community mental health, I got 15 minutes. So it's time to go, And so you end up using a lot of solution focused skills. And I would find that that'd be very helpful. I enjoyed that role because to a point, there's less setting in it, and as a therapist, you just spend a lot of time setting with people and letting them find it. Whereas a med provider, you'd spend a lot of time of what is your core issues right now? Okay, well, we need to get your food right, or maybe we need to just take this medicine, or can you get this medicine? Do you have a car? You're kind of working through some of those core components. I think when you bridge them together, there's this understanding of what the medicine's actually doing, not just at a neurological level, but at a thought and an emotion level. That's very different, right? We see where there's so much of that in like CBT and those kind of other modalities where this is what we believe is happening, right? By constantly challenging your thoughts, then therefore these new thoughts are going to be created. Well, what if I can give you a medicine that can help turn that emotion down so that you can actually challenge your thought? And so I think that's where you can kind of bridge them in. And so in that, like I think I have people, you never really know, but I think I have people maybe a little bit more bought in on their medicine just because it's going to give them the ability to do this other work rather than it just being like, here's Zoloft, good luck, man. I hope that keeps you not being depressed.
Yeah. I mean, it sounds a lot more holistic. So here's physically how, what this medication is going to do to your body, help tone your emotions down so that we can address X, Y, Z.
Yeah. And you know that in the psychology space, there's a lot of great work of, what therapy's doing at the neuronal level, right? I know Dr. Chad Luke, he's wrote some stuff on that in the clinical mental health space, of just what this is happening, right? Not just from BDNF, but all these neurotransmitters and all these neural connections. So can we help that with medicine and then bridge it together? That's really what you're trying to do, I think, as a med provider. It's just sometimes, do you have the time to explain it or not?
Yeah. Thank you.
Yeah. This is a great conversation. I mean, I think I'm going to kind of spin a little bit off of what Sean brought up, this idea of being a journey person, we'll say. And it's something we talked about last time, or at least a couple podcast episodes ago, about, people who have been practicing a while and you have all this wealth of experience. And when I'm talking to students as well as or new practitioners, there's always this transference, countertransference, and it's always kind of this fear of, I just need to avoid it. But I think that's something that can be really, part of the process of healing that can go along with it. And so maybe if you can talk about that when you're dealing with, high acuity, complex, treatment resistant people, you're inevitably going to come up with people that you're going to have some countertransference issues with. How do you work on recognizing that and maybe even keeping that from derailing your work that you're doing with those people?
It always makes me, I tell my students this a lot too. If I'm feeling this emotion about this person, how must they feel being that person? Right. And at the same time, how much must their family or the people around them to feel that way? Right. So of course I'm uncomfortable and I've got to check myself of being uncomfortable or just frustrated. But at the end of the day, no one wakes up and says, I want to make everyone around me uncomfortable. That sounds awesome. That's going to be very helpful to me from a societal level. And so we have to remember ourselves in that. I will say one thing that I think I love about being a med provider compared to being in like a director role and some of those things is med providers, we can jump in and kind of be there for 30 minutes, an hour, whatever that looks like. And then we're out. Whereas like, if you've ever been a director or have you ever done like therapy work on a unit, you're in it all day, right? The emotions there, you're kind of going through it day in and day out. So we have this ability to kind of jump in and kind of recognize where the countertransference is, not out of, hey, I need you to be nice so that everyone else is calm, or hey, I need you to do this so that my milieu looks good when the executive comes by. But I can experience the countertransference of this is what your ability to meet your needs does for me. And I think that in alone can be very helpful, creates a lot of empathy, and then it can kind of maybe guide you into what need they're trying to meet.
Yeah. Yeah, I like that idea. Again, it just feeds that information. I've always liked Dr. Marsha Linehan always kind of talks about that grist for the mill. It's grist for the everything is grist for the mill. And so that stuff that brings up within you. And I really loved how you said that try to put yourself in their shoes, and if they're making you feel that way, how much are they getting out of bed and thinking about that or feeling that way or experiencing those kind of hostilities or, vast intense emotionals from other people as well. So thanks. That's been great.
So Josh,
I used to have a professor who'd always say, if there's someone that makes you feel baffled, buffled, or confused, there's a reason why. And so anytime you're either baffled, buffled, or confused, it's like, okay, there's something going on here in this space that's doing that. And then I got to recognize it.
Yeah. It's almost better to recognize that than be like totally lost and confused, right? Let that guide you for sure. That's great.
So Josh, the podcast is namesaked around Hildegard Peplau, so I'm going to steer us back to some psychotherapy stuff. I'm hoping to give our listeners some practical guidance about a specific high-volume clinical scenario that we all encounter at different times during the day when we're seeing patients. I'm going to ask you to think for a second about how you would approach a patient whose psychiatric condition is not going to get better solely with the psychotropic solution, right? Based upon your experience, that part of this is psychotherapeutically driven, right? So my question for you, and hopefully that you can share this to our audience, which is a pretty good chunk of seasoned clinicians and students, right? How do you sell psychotherapy to a patient who is pre-contemplative as it relates to the value of psychotherapy?
Man, that's a good question. If I was really good at this, I'd probably be selling something besides psychotherapy. But yeah, I think that it's such a challenge, right? One of the things that I like to highlight is that if you're taking a medicine right now and kind of looking at your scales, whatever you use, right? Whether you're using scales, you're doing numbers, whatever. If I'm at like a 4 when I started my medicine and I'm at a 6, how does 6 feel, right? Is this how you want to feel today? Is this as good as you think you can feel? And if so, who am I to say that you have to get help? But if you're not, there is something else. And I think that's kind of how you sell it, as there's another ingredient in the toolbox. Do you have to do it? No. But it's kind of like someone putting something on the table and saying, I can make you feel better with some work that you can do with me. And that's kind of wild, right? To think about, I'm not going to give you something. You're not going to wake up and all of a sudden you're better. But wherever you're at today, whatever this medicine has done for you, if you do this other thing, one of the ways that I like to tell people when I'm kind of going through my different options, because I love to give people options, we'll say, I can give you this medicine, right? And it's probably going to be very helpful, right? We're probably going to see about 50 to 75% decrease in symptoms, sometime 100. That's what we have. If you just do therapy, right, you're probably going to have about a 50 to 75%, sometimes a little bit less, a little bit more. And if you just done like diet and exercise, doing all the things, kind of better. But if you do all three and you attack it in all 3 ways, you're going to get better. It may take some changes in medicines and those kind of things, but I think that's the selling point, is that, no, I'm not saying you have to, but if you feel exactly the way you want to feel right now, granted, we could say that there's some need concepts in that. And ultimately we could say like, well, I don't want to get better, and those kind of people. But I think that's the biggest thing in it, is that there is something else on the other side.
That's really cool. So that kind of helps me in my mind, and I'm kind of speaking to our students right now or listening, that it sounds like part of your strategy is, I'm going to roll with the resistance, and I'm going to continue to apply motivational interviewing techniques when they are pre-contemplative, looking for that opportunity to say, is this as good as it's going to get? Is this acceptable to you? And you just keep playing on the edge, looking for your opportunities down the road. Is that a fair way to say it?
It is. And I think one thing we have to remember is that for some people, they don't have a template of what it looks like to be well, right? And so when we engage in these conversations, we are making the assumption that they know what wellness looks like, right? But if you have that person that sits in front of you and you're like, well, when was the last time you didn't feel depressed? And they're like, never. Sometimes that is true. Sometimes they don't have a template of what wellness looks like. And so if that's the case, maybe it's stepping back and spending the time to say, like, what does wellness look like for you? Like, how would you know you're as healthy as you want to be? I was working with someone the other day where we were doing, in my model, I have like body, mind, environment, and spirit. And so we kind of talked about how would you be healthy in all 4 of those components? Because they have no idea. They don't know what being healthy looks like for them. And so what would it look like for your body to be healthy, or your mind to be healthy, your environment to be healthy, your spirit to be healthy? And I think that can be very helpful too. If they don't know where to go, there's probably a reason why. And we got to help them create that template.
That's beautifully concordant. Thanks. I'll pass it to Melissa.
My question is going to focus back on the rurality and working in rural settings. A lot of my focus has been in rural health as well. And I grew up in a rural area. My family lives in extended family, rural Iowa, rural Pennsylvania, rural Tennessee. And those
Yeah.
are all rural in so many different ways, right? Rural isn't like they're different. But what I found from my work and then personal experience is navigating in those settings, as you've mentioned, I kind of operate differently than I would if I was in Minneapolis, which is where I live now. I'm wondering when it comes to something like mental health, how you approach the folks you work with. Like, is it in crisis settings, or sometimes it's like if there's resistance, maybe you don't call it what we are talking about, like in this setting. Maybe it's more of like an indirect route. Sometimes like you meet people where they're at. And what does that look like, I guess? If you have any examples of going into a community, because I think that's something that if folks haven't worked in a lot of rural settings, it's unclear. Like as I'm mentoring people, like you can't come in and say like, oh, we're going to talk about, how did you feel about it? Like we don't do that. That would be shut down immediately in a lot of these settings. So what does that look like in your work?
Yeah, I mean, I tell students all the time, and then used to when I was at the community clinic, and we'd bring people in. When you come in, you need to get in your car. You need to drive around that entire town. You need to know what those streets are that they're talking about. You need to know what it means to go down into the holler. You need to know those things. You need to know where they're spending their weekends at. I mean, you need to know what life looks like. And I know for me, being in Northwest Florida, driving those roads and realizing I haven't seen a store in 35 minutes. Oh my gosh. Let's kind of think about that for a second. Or I have not seen a single bus stop since I got on this road. Oh, there's no public transportation here. I think those are the things that you have to know. It's very easy to kind of assume that those things are there, and they're not. And then I think you can learn a lot just driving back roads. Be careful, especially in some areas, but drive some back roads and look at some of those things. Look at what the houses look like. Look at what life looks like. Are there even jobs around? If you want to like see some stuff, you can get up in Appalachia, but also like here in Florida, you'll go 2 hours without ever seeing any kind of large, building that someone would work in, right? What's the job situation like? I think those are very, very important. I remember when I was in East Tennessee and I was working up there as a therapist, one of the things that you kind of learned is how everything goes with seasons. And it's very similar to here too, but recognizing that like, hey, all my people are going to make money from this time to this time. So if they don't show up for their session today, there's a reason why, because they're trying to make money, because their money chance is going to stop in maybe 2 more months, and so you kind of just recognize those seasonal movements and those things. And I think all of that can be very helpful in understanding why people do what they do based on the areas that they live in.
I love that. I feel like you've just legitimized, like I have experiences driving around Vermont and switchbacks, and I was terrified because I'm like, I can't see around this. And it's like such a narrow, right? It matters so much to immerse yourself in those communities so you can understand. Thank you.
Yeah. I mean, you're driving in there and you're like, that road's not paved and that road's not paved. And so you're, none of these roads are paved. Okay, now I need to put in a 4-wheel drive a little bit. Gotta see where I can go. It's a very interesting concept, but I think that's what makes you good providers, knowing the area that you're in. I think there's a lot of people who they'll go and, I always try to eat local anyways, but if I can go to the local store, like I try to get everything I need in the area that I'm working in, just so I kind of know it. You'll see them out and about, and that can kind of be a little uncomfortable, but at least they know you exist and you're part of the community. That can be pretty fun.
That's awesome. Yeah, I think, it reminds me back getting my RN, we had a community nursing class and we had to go out in communities. And one of the things I'll always remember is when you look at the road, you look to see if there is a curb. And the curb means that there is a sewer system usually attached to that, so that rainwater and other things can. So if you're going through a town that doesn't have a curb, that might not have a sewer system. So that's an interesting kind of, part of that, just like you were saying, unpaved versus paved kind of roads. So this has been awesome, Josh. We've got kind of our last, what we kind of will call our parting question, but then I've got a question that our previous guest has for you as well. But before we get to that, what are some advice that you would give to other PMHNPs currently practicing, or like Sean said, some students who might be listening to this as well, as a journeyman, as with all this experience? I mean, I think part of your desire and your teaching at Yale University and other places, I think you want to pass what you've learned, your information on to others. So what is some parting information for the profession of PMHNPs, and where Hildegard started us off, and where we are today, and what the future looks like for you?
Man, I can get on a soapbox. So if you need to cut me
Go
off,
preach. Let's go. Yes, right there.
Shut me down, man. Because I get on tangents all the time about stuff like this. I mean, I think that, we can all get real, right? Healthcare in America is super broken. I mean, it's wildly broken. We can all talk about it. It's a very broken system. And so one of the things that we have a really awesome opportunity is, can we help fix the brokenness of that system, right? And I think that's where PMHNPs, all nurse practitioners really have a seat at that table, right? Is to help fix a lot of this brokenness, whether it's, as Sean was saying, maybe many of us are just journeymen that are kind of coming into this space, or the training that we get is very different. It's a little bit more holistic, a little bit more integrative, especially in most universities it is. So we have a space to be that. So if you're a student, be thinking about, not only can I earn myself a seat at the table, which is unfortunate. It's kind of uncomfortable to say, but you have to earn your seat at the table, right? Do I know how these medicines work? Do I know how these diagnoses emerge and exist? That gets you a seat at the table. And then once you're there, can you change the conventional system that's there, right? Maybe we don't do that exact thing. Like I was telling some of my students the other day, each person has a specific trait that brought them to be a nurse practitioner, right? And many of us is investigative or empathic and those kind of things. But from that is also their way to impact their community. And so it's not only do you learn how to help people, but how can you change some of the systems that are there? And I think we all forget that we have that ability to do that. That's the cool thing about being a nurse practitioner is you can change these systems. You see nurse practitioners now, they're creating these community gardens in these cities where they're kind of helping people get good food, or they're doing some stuff at the leadership level where they're trying to create integrative kind of practices where primary care and other specialties are kind of getting involved. That's cool stuff that we can do and be a part of. So just know the training you're doing now as a student, that's going to get you a seat at the table and get you to help people. But then from that, how do you find your niche, if you will, for that moment?
I love it. Yeah. I always tell, and that's a great way to kind of end it, I think, because it's, it's one of those positive, it's more of an upbeat type of thing. Because you're right. We could go down a rabbit's hole about how the system and, you said the healthcare system in general, but yeah, the mental health system across the country is really broken. And, but I think you're right. It's a great time to be a PMHNP because we have the training, we have the holistic approaches. We've got all the things we need to really kind of, like you said, have that seat at the table. So, all right, I'm going to transition into our previous guest. Dr. Paula here is going to ask you a question. So let me share real quick.
All right, so we have Dr. Paula Alaka here with a question for Dr. Josh Waddell.
Hi, Dr. Waddell. My question for you is based on the immense number of practice settings that you've been able to participate in. So my question to you is, do you have any recommendations for new graduates on the best setting to get started in when they're beginning their practice?
Thank you, Dr. Paula. Yeah, Josh, take it away.
I'm a big believer in every student getting in community mental health. There is no place in the country you're going to see more people, sometimes to your demise, but more people with the vast amount of diagnoses and the vast amount of medications you ever see. I mean, the statistical chance of you prescribing an MAOI is really low. You get community mental health, it's going to happen. Give yourself some time. It's going to happen, right? And so I'm a huge believer in just getting community mental health. Now, the big thing you've got to know is when it starts to weigh on you, right? Because for some people, a year is enough. For other people, they do it for their whole career. They're just kind of wired for that. And so there's a lot of self-work that needs to be done, a lot of mentoring that needs to be done, because when it's time to go, it's time to go. When it's not serving you and you're not serving them anymore, make a shift. But I'm a huge believer getting in that space. I think acute settings are great, but I think it's really challenging, and I know you guys have worked with people in this space too. If all you've ever done is acute, it's very challenging to know how to manage and titrate meds on the outside and in the lab work and the social concepts. So get in community mental health. There's a need anyway. Sometimes you can get your loans paid off if you're at least lucky enough to get some of the federal loans back in the day, and just get in there, do the work, learn, and then, the world's your oyster after that, because you're seeing 5 to 95, every diagnosis that exists in there. I'm just a big believer in that space.
Love it. Yes, exactly. Yeah. We talked about that before too. I think there is some concern and like you said, for that autonomy and wanting to practice how you want to practice, I know I see a lot of my students kind of going into private practice and not getting that community experience. It's going to be interesting how the future kind of, shapes their worldview and their professional outlook on things. But I think that's a great thing to say. So want to just wrap up here by saying thank you to Dr. Josh Waddell. Thank you so much for being here. This has been amazing. I'm inspired. My cup is fuller. And if you want to listen to more to Josh, he does have a podcast, Mental Maps. Check it out. He's got new episodes coming out as well. But we'll have some new episodes coming out in a week or so. But thank you again, Dr. Josh Waddell. Those of you listening, make sure you like, subscribe, send those comments. Please let us know. Have a suggestion for a guest? Let us know. All right. Take care.
Carrying the torch through the blood and the rain. We are nurses, the world can't forget. We give our all, no regrets. Modern in our ways, but our roots don't decay. Nurses anthem and it's here to stay. We are nurses.
So here's to the hands that heal, the hearts that stay steady, the voices that whisper you're not alone. Because nursing isn't just what we do, it's who we are.